All right, here we go with Chapter 15, care of the intraoperative patient. Remember, the intraoperative is when the patient first enters the surgical suite, and it's going to end when they transfer them to the post-anesthesia recovery area. So the main concern for intraoperative nurses is safety and patient advocacy by preventing, reducing, controlling, and managing hazards. The patient in the OR is at risk for, and these things are important: infection, impaired skin integrity, increased anxiety, poor thermal regulation, altered body temperature, and injury related to positioning. So your positioning, your skin integrity, all of that stuff, the nurse is going to assist this patient, especially since they can't move themselves and can't reposition themselves, to make sure that they're not receiving any kind of injury. If a surgery is going to last for an incredibly long time, like maybe 10, 12 hours or something to that nature, obviously the patient's going to need to be moved a little bit so they're not just laying in the one spot the whole time. Also, if repositioning has to happen, that we're ensuring that we're not going to be, trying to roll them over an arm that's bent funny and causing injury that way. So there's things to think about. Infection as well, that's part of the whole sterile procedure and making sure everybody stays sterile, because we can introduce infection if not. So the different members of the surgical team, the surgeon and the surgical assistant, the anesthesia provider, the holding area nurse, the circulating nurse, scrub nurse, or scrub tech. So the position in which Frank holds that he's shared with us as a surgical tech, some hospitals will use a scrub nurse, but they essentially do the same thing. The circulating nurse is that one we kind of talked about. That would be the one to call the timeout, and the one who's going to oversee all of the nursing care within the OR. So prepping the OR, the OR layout helps to prevent infection. So you can read the different things by reducing contaminants, counts. So all of the instruments that are used, and sponges and everything else, sharps, instruments, everything that's used there is counted before, during, and after the procedure. And I want to say it's counted twice at the end, if that's what I remember reading in the book. So scrub attire is worn by all OR personnel, and is provided by the hospital, and staff changes in a designated surgical area, not at home. So that way the hospital somewhat can control how much this clothing is exposed to and what. It is not considered sterile, but it is considered clean. So minimally invasive and robotic surgery, okay? MIS is the minimally invasive surgery. This is now the more common practice. So surgeries that used to open people all the way up, especially abdominal, in their abdominal cavity, no longer have to be, because we can do minimal invasive surgery. So many different surgical techniques. Some are listed here for you, but that's not all of them. They also do hysterectomies robotically, or, I know they do it even laparoscopically, but all these other things can be done. And I'm sure there's others too. These are just examples of things that can be done. So lots of things are done minimally invasive. So endoscope, that's a tube that allows viewing and manipulation of internal organs, internal areas. So you got a couple of different examples of where, like laparoscope is the abdominal, arthroscopes is for joints, ureteroscopes is for urinary tracts. The benefits are listed there for you, but many people, their research has found that it will decrease the recovery time afterwards. Obviously, they don't need to have a big, huge incision, less blood loss, faster recovery time, and less pain. Insufflation is an important part of surgery, and for nurses to understand patient care. This is injecting gas or air into the cavity before surgery to separate the organs. This can contribute to complications and patient discomfort. So if any of you have either known somebody or yourself have had specifically abdominal surgery where they had to inflate the abdominal cavity with a certain type of gas in order to this separates the organs, so the surgeon can see better, can know exactly where he or she is at. Afterwards, many times the patients will move up into their shoulders, or maybe up like in their chest region, and so they have tons of pain and hard times moving those areas, as shoulder pain tends to be the primary complaint. And if we get them moving and moving quickly, that actually helps quite a bit. But again, patients are resistant because it hurts so much. So that's one thing that we need to be aware of, especially if we take care of patients after surgery. So the environment of the operating room. So we've kind of talked about the layout and the way it's set up. Health and hygiene of the surgical team. We know that, you know, they're going to change their clothes at the hospital, not at home. Remember that people are a source of bacteria in the surgical setting. Special health care standards and dress are needed, and watch for nosocomial infections. You're going to want to make sure you know that. I'm sure most of you do. Identify a source of pathogens. So we got to find out where those came from so we can prevent it from happening again. So surgical scrubbing, a lot of you will get to see this when you go to an OR setting during your rotation, but you'll get to watch the surgeon do a surgical scrub. So they use a broad spectrum surgical antimicrobial solution, and it's vigorous scrubbing that creates friction used from fingertips to elbow, and the scrub continues for 3 to 5 minutes. And then this right here is straight from your book. You can walk through that as you're reading that chapter, and hopefully you have already read that chapter, but it kind of walks through what the surgeon's doing in his or her surgical scrub. So anesthesia, there's a picture of propofol there, also known as Diprivan. That's the one that I said, remember, kind of, that's the drug that Michael Jackson overdosed on. But general anesthesia itself is reversible loss of consciousness, so we can wake them up. It depresses the central nervous system, resulting in analgesia, so that's pain suppression and relief, amnesia, which is memory loss, and unconsciousness. We give this with either an inhalation or intravenous. So neither one of these would have a first pass. Combination of medications used to achieve balanced anesthesia. So you'll see an example of that at the bottom there would be like giving morphine, Pavilon, and propofol, all of which work in different ways to achieve this combination of anesthesia. Complications, we've already talked about malignant hyperthermia, and you guys have received a handout on that. Overdose, if a patient's metabolism is slower than expected, we may, again, because we talked about this actually today in Pharm, if the metabolism is slower, then that means the drug is going to be built up longer. So that's with patients who have kidney or liver disease, and maybe we don't know that. Unrecognized hypoventilation, so inadequate gas exchange. This can lead to coma, brain injury, or death, so super important for us to watch that stuff. And then intubation problems, like improper neck extension, if the patient had broken teeth or dental repairs that we didn't know about, or that we caused broken teeth. Small oral cavities can cause problems. Vocal cord trauma can result. So there's a bunch of different things that can happen during the intubation. I'm not going to go through malignant hyperthermia again because we actually talked a lot about that at the last class, but make sure that you do know what it is, that we're asking about it, and that what we can do to help it if it does happen. So local anesthesia. All right, something happened with my recording, so I have to go back to local anesthesia. Here we go. All right, so different local anesthetics. So this is either briefly, okay, so local anesthesia. Anyway, local anesthesia, the patient remains conscious. They're able to follow directions. You can see down here the different local anesthetics. Lidocaine will probably be the one that you're most familiar with. Disrupts sensory nerve impulses transmitted to a specific area of the body. And that, we use that just so we can numb one area in order to perform. Patient is awake the whole time and we can ask them how they're doing. Regional anesthesia, so these are things like a field, nerve, spinal, or epidural. These are blocks, basically. They block at certain peripheral nerves, so any women that have had children may potentially experienced an epidural or a spinal. If you were having a C-section and knew it, they just start with a spinal. So that's what this part is for regional anesthesia. So see pages 248 through 249. It just kind of shows the different positions and where these different needles go depending on if it's epidural or if it's block or if it's spinal. So just go over that and see it for yourself when you're studying for this. Moderate sedation, also known as a conscious sedation, is IV delivery of some kind of sedative, hypnotic opioid drugs to reduce level of consciousness. Patient maintains their airway and can typically respond to verbal commands. The amnesia action is short, so typically they don't really remember. They may remember right before they went to sleep, but even though they respond to you and can say yes and no, or, you know, if you tell them to do something, they can do it, they don't typically remember it afterwards. And one that, you know, we used to use a lot in the ICU to do procedures at the bedside was Versed. But you can see there's others listed there. Oral intake is not permitted until 30 minutes after the patient has received the sedation or after you have a patient order. That's from your book. I would always make sure that it's once your patient is able to, you know, they're awake, they can like maintain themselves. Your airway is what you're always going to be most concerned about. So collaborative management, a lot of this stuff is stuff we've already talked about medical record review, allergies, and what's happened prior with anesthesia. Again, that question's mostly related to malignant hyperthermia. We've talked about autologous blood transfusions. We've talked a little bit about laboratory and diagnostic testing. Advanced directives and DNR. So one important thing about this is some agencies suspend DNR orders, so that's do not resuscitate, while the patient is undergoing a surgical procedure. So it's going to depend on the agency, the policy, or maybe even the doc, if a patient's DNR is basically inactive while they're in the surgical suite. So there's your different common surgical positions. Be familiar with those positions. So potential for injury, obviously, we talked about this sort of at the beginning. Patient is at risk for injury if we're not watching for different things. So again, proper body position, preventing pressure ulcers. Those are going to be the important things the nurse is watching for. Preventing infection. Again, so you've got your different interventions listed there that you guys can read through. I don't need to read them to you. And then expected outcomes for these wounds afterwards. We don't want the wound to have purulent drainage. We want the patient to remain afebrile. We want white counts to stay at expected levels. So these are all things like if you're building a care plan and you're doing nursing diagnoses, these are these expected outcomes that we're hoping for that patient. I just put this on here for just to show you the different things that we do for closing up wounds. I'm not going to ask you anything about those. Potential for hypoventilation. So be sure to read pages 250 through 255 for an in-depth look at nursing care for this patient. So breathing is really important. Airway obviously is very important. As nurses, we are typically one of the first ones to identify and notice that something is changing because we tend to be the ones that know the patient the best. And even in an OR setting, I'm sure the circulating nurses, especially during long surgeries, they're doing so much maintenance of the patient that they're picking up on these cues early. So make sure that we're always monitoring for the hypoventilation and the airway. So that is it for this chapter, and your next one will be up shortly.